Thank you so much for having me. It's a delight to be here live, and I welcome audience both here on site and those joining virtually. So we'll start a discussion about comorbidity. These are my disclosures. First, I'd like to ask you a polling question in terms of comorbidity. Are you aware of the concept of multimorbidity? And please vote. Okay, so some votes are coming in. We'll wait a little bit. Honestly, it was somewhat a confusing concept to me initially as well. And so what we see is majority are somewhat aware, but don't quite understand how is it different from comorbidity, which was my case as well. All right, so today we'll go over the concept of multimorbidity itself. We'll discuss the epidemiology of multimorbidity in patients with rheumatoid arthritis. We'll talk about the role of multimorbidity in outcomes in rheumatoid arthritis. I'll touch upon the emerging concept of multimorbidity clusters, and we'll discuss approaches for screening and monitoring of multimorbidity. So what is multimorbidity? It's a coexistence of two or more chronic conditions. It's not mutually exclusive or contradictory to the concept of comorbidity. In multimorbidity, unlike comorbidity, the center of the concept is the patient, and all the conditions are centered around him and or her, and so the major difference is that it's more patient-centric rather than disease-centric, and it's more helpful to think with the concept of multimorbidity in mind when you're thinking about healthcare delivery and optimizing the healthcare and outcomes for a patient. In comorbidity, we center around an index morbidity, for example, rheumatoid arthritis, and think about other morbidities related to that index condition, either through causality or coincidence or through complications due to medication use, for example. Multimorbidity is more holistic concept, and like I said, it's more of a complementary or broader concept than comorbidity. Why is it important? It's a growing problem, especially with the aging of the population. And in fact, systematic studies of multimorbidity have been encouraged by the US Department of Human Health and Health Services. So the prevalence of multimorbidity in general population vary widely, but about 1 in 4 people would have multimorbidity. Of course, numbers vary depending on age group, depending on geographic location, depending on socio-demographics. In rheumatoid arthritis, we know that multimorbidity is more prevalent. How is multimorbidity measured? So there's a number of indices that can be used, and some of them use simple count of morbidities. Some of them weigh morbidities depending on their impact on the outcomes, including quality of life, healthcare utilization, mortality, and so on. For example, solid malignancy would be weighed higher than, for example, peptic ulcer disease, which makes sense. But when you receive this score or an index, what do you do with it? So it's not very helpful in terms of healthcare management for a patient. And there's also a gap of no single useful clinically applicable method of measuring multimorbidity. So the studies I will be presenting used different indices, and how they compare is not quite clear. Epidemiology of multimorbidity is a growing area of research. A lot in that area was done by the group from Nebraska, led by Brian England. They used MarketScan database, and for example, in this study, they found that over 50% of patients have multimorbidity. Multimorbidity is twofold more prevalent in patients with rheumatoid arthritis as opposed to general population. Patients with rheumatoid arthritis have higher number of chronic conditions than general population. Most overrepresented conditions that they found were ILD, fibromyalgia, osteoarthritis, osteoporosis, and you would say, wait, these are all conditions related to rheumatoid arthritis, so it's not surprising that the number is higher in RA. But the researchers actually have done the analysis of excluding these RA-related comorbidities, and so the upper graph represents number of morbidities overall in RA and the comparison population. And here they excluded the RA-related morbidities, and the numbers are still higher in RA. So the next important finding from this study is that the heightened burden of morbidity starts early in the disease in patients with rheumatoid arthritis and frequently precedes the onset of rheumatoid arthritis, and then it accelerates faster in terms of accumulation in RA as opposed to non-RA population. So there's some of that funneling, some of the funneling of the difference in morbidities and a growing excess in risk of having more morbidities in general in RA as compared to non-RA. So this is important to recognize, and this study comes from our group using Olmsted County, Minnesota population and our population-based cohorts of RA patients and patients without rheumatoid arthritis who were followed for extended period of time. We detected that incident multimorbidity state is 40% more likely to develop in patients with rheumatoid arthritis as opposed to non-RA population. Interestingly, we found that at onset of RA, seronegative patients tend to have more morbidities, and that can be because they are evaluated for differential diagnosis slightly more, but they are not more likely to develop morbidities or accumulate morbidities faster later on as opposed to seropositive. Also, our study and important finding from this one is that multimorbidity is disproportionately higher in younger age group. And that's important to keep in mind. If you have a younger patient with rheumatoid arthritis, make sure to screen for morbidities and define whether or not they are multimorbid. How about role of multimorbidity in outcomes in patients with rheumatoid arthritis? So this study, Nurses Health Study database, they used weighted multimorbidity index, and again, similar to previous studies, you see how there is a gap in the number of morbidities between RA and non-RA population. Important findings from this study are that they found that multimorbidity contributes to excess mortality. And interestingly, when they accounted for multimorbidity in their analysis, excess mortality, especially cardiovascular mortality, less so total mortality, decrease, the excess and risk decrease, suggesting that multimorbidity contributes significantly to overall and cause-specific mortality. This was not as much the case with respiratory mortality, potentially due to disease impact, rheumatoid arthritis disease impact, and some environmental factors potentially. Other studies, including the study using UK Biobank, also analyzed the role of multimorbidity on outcomes. And so similarly, they found threefold increase in all-cause mortality and major adverse cardiac events in patients with multimorbidity and rheumatoid arthritis. Among the comorbidities, and by the way, of course, common things are common, so the most common comorbidities in multimorbidity in both RA and general population would be hypertension, diabetes, and such. But among the comorbidities, osteoporosis, they found was associated significantly and was somewhat driving this association with overall mortality and major adverse cardiac event. They didn't have analysis for association with glucocorticoids, which could have confounded this finding. How about other outcomes? So fatigue is a very patient-important outcome and something that we hear from patients a lot. So this COMEDRA cohort study evaluated the role of multimorbidity and its role in severe fatigue. They found that multimorbidity overall, and particularly morbidities such as obesity, anxiety, and depression, were associated independently in their analysis with severe fatigue. In our cohort in Olmsted County, we also found that having each additional comorbidity increases the index of fatigue, Bristol rheumatoid arthritis fatigue risk score, by at least 2 points, and then having more comorbidities has more impact. So it's important to think about it when you consider patients who complain of fatigue and think about their multimorbidity status. How about functional disability, another patient-important outcome? Majority of studies agree that multimorbidity contributes to functional disability, and this is one of the earliest studies by Helga Rodner et al., who showed that even in patients in remission, that's shown in this green line, growing number of comorbidities and higher Charlson comorbidity index was associated with increased health assessment questionnaire score, and certainly the impact was even higher when patient was not in remission. In our cohort in Olmsted County, we found that multimorbidity does not have differential impact on functional disability between RA and non-RA population, and it's not one of the major drivers of converting from no functional disability to functional disability, suggesting that RA itself also plays important role. Another important topic is the role of multimorbidity in treatment outcomes. So this study was a cross-sectional study enrolling patients with rheumatoid arthritis, and they found that increased multimorbidity count was associated with lower odds of biologic DMARD use and specifically TNF inhibitor use. So there is a question whether, why is it happening, whether patients are less likely to be started on their medications, whether they are less likely to be adherent or tolerant of their medications, and whether or not patients with RA and multimorbidity are undertreated. There were several subsequent studies to address this question. This study using RISE registry showed that multimorbidity was in fact not associated with a new DMARD initiation in active rheumatoid arthritis, meaning that multimorbid patients were not less likely to be started on new DMARD as opposed to those without multimorbidity. But it was associated with lower odds of achieving treatment targets, and this was somewhat dose dependent, so the growing number of multimorbidities showed higher impact. This study from BRASS registry showed that in patients with rheumatoid arthritis, each comorbidity contributes to 30% lower likelihood of remission as opposed to no comorbidity. They matched patients with rheumatoid arthritis depending on the number of morbidities, and here the groups are 1, 2, and 3 and more morbidities with non-RA population, and compared remission and low disease activity states. And you can see how these gray bars, RA only, are higher in terms of levels, number of patients in remission and LDA as opposed to RA with multimorbidity. They also found that each comorbidity decreases the odds of being on the same initiated DMARD after 1 year. So this is a new finding and important finding in terms of medication survival in these patients. Next study using RAMS database showed that multimorbidity, and specifically having over 2 comorbidities as opposed to no comorbidities, was associated with non-adherence to methotrexate. There were other studies suggesting similar findings for TNF persistence. This prospective study in Belgium, which was a pragmatic 2-year trial, showed that patients who were treated to target and were on combination treatment and who had at least 1 comorbidity as opposed to no comorbidity had lower odds of achieving DAS28 remission. So certainly having comorbidity or state of multimorbidity puts patients at higher risk of being less successful in terms of treatment, and that can be for multiple reasons, as I mentioned, non-adherence and potentially less tolerance to medications. Next, I would like to introduce this concept of multimorbidity clusters. As I mentioned, the scores are not too helpful for us to sort of translate this knowledge of multimorbidity to clinical practice. So several research groups have addressed that in different ways, and I'll go over that. The study using BRASS registry, and the first author is Jeffrey Curtis, they detected distinct patient phenotypes and noted that these phenotypes have different outcomes over a 2-year follow-up. The phenotypes differed based on RA disease activity, RA disease duration, and comorbidities or state of multimorbidity. And they used cluster analysis to define these phenotypes. One of the outcomes was change in CDAI score over 2 years, and you can see how the phenotype that is marked in red is less successful or shows less improvement in terms of CDAI over the course of the observation as opposed to some of the other phenotypes. So there is definitely, it's definitely important to recognize what exact phenotype patient may be in and how that impacts on his prognosis going forward. Some other studies defined patterns of multimorbidity in patients with rheumatoid arthritis. This one used MarketScan and Veterans Health Administration database. This study determined that cardiometabolic, cardiopulmonary, and mental health and pain disorder phenotypes are predominant in patients with rheumatoid arthritis. Ironically, these phenotypes were also one of the most common in patients without rheumatoid arthritis, and there was no gender or sex difference in these leading phenotypes. But these phenotypes were much more common in patients with rheumatoid arthritis, suggesting more impact and need to improve management and optimization of outcomes. Next, these same authors connected the different phenotypes and clusters to outcomes and healthcare utilization. So they, based on the index, RDCI, Rheumatic Disease Severity Index, they determined that clusters of patients who have lower multimorbidity are less likely to use healthcare services as opposed to those who are in severe phenotype of multimorbidity. So that makes sense. And then they determined that there is also a mental health and chronic pain cluster, which was important because this cluster was actually associated with higher mortality. And now, in terms of healthcare utilization and healthcare management in patients with multimorbidity, it's actually not a new concept and has been applied in other chronic conditions, cluster medicine. So cluster medicine is being used, for example, in diabetes. We know that when a patient with diabetes comes to see endocrinologist, it's almost anticipated that he may also need at some point ophthalmology care, wound care, nephrology, and so on. So this concept has not been applied to, for example, rheumatologic diseases as much. And it actually helps to think about conditions that can be predicted to occur in a patient going during his follow-up to plan and organize and manage care, which results in more patient-oriented care and higher satisfaction. My next polling question is, do you assess and screen for major morbidities and risk factors in patients with rheumatoid arthritis? This is a segue to our next section of the talk about screening and management of multimorbidity. You can start voting. Very good. Oops. I'm not sure, maybe not. Didn't seem to register. All right, but by show of hands, maybe who is in the group who does, oh, okay, so we have it. So I guess 50-50. Some do screen and some do screen always, and some do it occasionally, and some leave it to primary care provider. All is fair, there's no right answer. In fact, there is very little guidance that we have from the society guidelines. EULAR issued these points to consider on selected comorbidities and rheumatic diseases, and that's pretty much all we have on management of multimorbidity. So they selected most prevalent and most impactful comorbidities in patients with rheumatic diseases, and those would be cardiovascular disease, malignancies, infections, osteoporosis, peptic ulcer, depression, so all makes sense. They did recommend generally to carefully assess and manage these comorbidities and screen and detect comorbidities not only by evaluation but also by patient self-report. They do recommend assessing multimorbidity state periodically, or at least every 5 years, and certainly screen for current history of disease, history of disease, risk factors for disease, prevention, and that includes immunizations, and potential treatments that can be associated with a risk of comorbidities as well. So a group in France took these guidelines and tried to implement them in a multimorbidity clinic. They did it for 1 day, and they detected that really it was successful, it was efficient, it was feasible. They detected a few gaps in healthcare in patients with rheumatoid arthritis. They detected that 60% of patients had at least one or more uncontrolled comorbidity. However, there were a lot of challenges that they also recognized, including its being effort-consuming, time-consuming, potentially not cost-effective. So there's a lot of room for additional studies. This study in the UK used nurse-led integrated primary care review for identification, assessment, and initial management of common comorbidities. Again, they found it feasible, they recognized significant multimorbidity burden, and they improved prescribing practices for these patients, especially for osteoporosis. So if anything, recognizing multimorbidity and helping patients to manage it would be an important contribution that we as providers can do, because indeed it's not an easy task for a patient who has already a rheumatoid arthritis or other rheumatic conditions to additionally have to be responsible or manage other comorbidities in excess of 2 or 4, sometimes higher, on their account, and manage the treatments, appointments, and all the healthcare burden that's associated with that. Another study that enrolled elderly patients with rheumatoid arthritis and multimorbidity focused on personal goals, and they followed patients for 1 year and found that majority of patients accomplished those goals and were satisfied with the result of this intervention. Again, medication adjustment was one of the main positive points that this study noted. The long-term benefits they couldn't comment on beyond the year that they observed those patients, and then they recognized that referring patients with multimorbidity is challenging, and there is no clear criteria for selection of the patients for the clinic. So a lot to work on. Somewhat of a futuristic example, but this is a platform, a connected care platform that was designed in Europe and used and trialed on patients with rheumatoid arthritis in Germany. Patients work with a user-friendly dashboard that includes self-reported answers to the questionnaires, as well as information from wearable devices, which then translates to their providers. And this, in this model, it was found to be a positive impact in terms of management of multiple morbidities due to easiness of connecting between patient and provider. So it follows the line of minimally disruptive medicine, where patient who is very sick really doesn't have energy or time or sometimes resources to holistically manage his own care, and certainly needs somewhat of an easygoing way to report and communicate his complaints and symptoms to providers. All right, multiple choice questions as a recap on the multimorbidity and its impact on the outcomes. Please vote. Yes, okay. All right. Okay, I'll advance. All right, so many of you say all of the above. I would say that a poor response to antibiotic treatments, as we discussed, is one outcome, and then increased mortality is another, increased hospitalizations as well, but not as much of good adherence to antibiotic medications. So all but that treatment adherence response. All right, so in summary, I would like to highlight the increased and growing burden of multimorbidity in patients with rheumatoid arthritis and its significant and unfavorable impact on multiple outcomes, including functional disability, mortality, response to treatments, healthcare utilization. There is emergent concept of multimorbidity clusters or patient phenotypes with multimorbidity that may help to bridge the knowledge of multimorbidity with clinical practice. And we'll see going forward, multimorbidity definitely makes RA management more complex, and there is a potential for artificial intelligence and machine learning, not only in research, but in clinical care for these patients. Certainly, holistic approach to patient care is encouraged in this difficult to manage population. And it would be nice to have clinical guidelines for rheumatoid arthritis that would incorporate multimorbidity. I would like to finish with this slide of clinical implications, as this is something that's probably key takeaways from this talk. If you don't remember anything else, please remember this. Awareness of multimorbidity is a must. If you can prevent patients from developing a state of multimorbidity, that's great. It's not always feasible, and sometimes patients come to us with the state of multimorbidity already. So in that case, recognizing it, helping patients to manage it, coordinating their care, helping them and explaining them their medications and dosing would be important, and certainly multidisciplinary care, team-based care model would be ideal for that. And patient engagement in care is always important. Thank you so much for your attention.
Elena, that was excellent. A number of questions, but let me give you a few, and then we'll take the rest at the panel. Given that there's issues of maybe non-adherence and issues of safety associated with multimorbidity, does that color the therapies you use? Should therapy be chosen on this basis? Is there better therapies for the management of comorbidity or vice versa?
Yeah, thank you. Great question. That in general, patients with multimorbidity or a number of comorbidities are more difficult to manage, and we start thinking what contraindications they may have, what they may be able to tolerate better, what side effects from medicines that they are likely to develop. So I guess the choice of the medicine would then depend on the combination of morbidities that they have. So it's more or less straightforward in terms of thinking, but easier said than done.
Mm-hmm. Somewhere earlier it was said that seronegatives have worse disease. In some way, do the difference between seronegatives and seropositives as far as multimorbidity again?
Yeah, so that was a finding that we had from our cohorts. Patients with seronegative rheumatoid arthritis had more morbidities at the start, at the incidence of their RA, and so we thought that one potential explanation could be that physicians are searching for diagnosis more thoroughly in these patients because they are uncertain whether what patient has is actually rheumatoid arthritis, since there's no markers, and they do evaluate for thyroid disorders, they do evaluate for fibromyalgia and so on, and so that accumulates in terms of the list of comorbidities that they have. Seronegative patients were not more likely to accumulate morbidities at a higher pace than seropositive patients, which kind of supports this initial observation. So I guess more research would probably be needed to understand better how seronegative and seropositive patients differ in that sense.
Okay. All right, we'll take the rest of the questions at the panel. Thank you very much. Our last lecture of the program is from Karen Kostenbatter from Harvard. We asked Karen to address the easy topic of preventing rheumatoid arthritis.